Thank you, Justin. Good afternoon, everyone. I want to bring to your attention on the table there is a position paper, which is a draft position paper. This organization in the Healthcare IT Summit is sponsored by the Technology Association of Georgia, the Economic Development Authority, and the Metro Chamber. I almost forgot for a second. And they have all approved this position statement, but it is a draft version for all of you to look at, to consider, to provide comments on. So feel free to reach out to TAG, the Metro Chamber, or the Economic Development Authority if you think anything in here needs to be changed, or if you have comments that you'd like to add to it, and especially after our session this afternoon. And the purpose behind this is so that when we're done with the summit, we can actually take what we've learned here and what we've shared as colleagues and as individuals and organizations involved in healthcare IT and really use it as a foundation growing block within the state of Georgia. So what can we take to the state legislature? What can we take to other organizations to further support what David said this morning about Georgia being the healthcare IT capital of the world? And so with that, it is my honor to moderate this panel on public policy, and I would like to introduce our panel this afternoon, who are all very graciously agreed to let me pepper them with questions. And they also have come with esteemed backgrounds from various areas that I think all will impact the public policy arena. So we're going to start on the far right side of the panel with Dr. Warren Hutchings. Dr. Hutchings has been practicing family medicine in his hometown of Macon, Georgia, since 1993. He's an assistant professor at Mercer University School of Medicine, where he's also the medical director for the Mercer Student Health Center. He is the team physician for the Mercer University Athletics, and he reorganized the Macon Academy of Medicine, Dentistry, and Pharmacy. He founded and currently serves as the president of Middle Georgia Medical Society. He is the CEO of the Middle Georgia Medical Society and is president of the Georgia State Medical Association. He also serves as an IPA of Georgia's Middle Georgia Medical Director and serves on the executive committee of AVBA. He was also appointed to the Georgia Health Information Exchange Board in 2011, and we're going to hear more about that this afternoon. And he is a graduate of the Morehouse School of Medicine. And that is Dr. Hutchings on the far right. Next to Dr. Hutchings is Kelly Gonzalez. Kelly Gonzalez is the Director of Healthcare Information Technology for the Georgia Department of Community Health. She serves as the interim State Health Information Technology Coordinator, and for the Georgia Department of Community Health, she's responsible for the IT roadmap, coordinating key stakeholders across the state for health and human services, and with a focus on transforming the delivery of healthcare. She is also key in orchestrating the development of the technical infrastructure that we're all focused on in the state to effectively leverage the state's IT assets and enable interoperability, which is a key word that we're all struggling with. She received her bachelor's degree in economics and management in English and literature from Beloit College in Wisconsin, and her master's in information systems from DePaul University in Chicago. She is currently pursuing a master's in human-computer interaction from Iowa State University. So that's Kelly Gonzalez. Next to Kelly is Senator Unterman. Make sure I have all of my notes in place. Senator Unterman is the chairman of the Health Committee for the Senate in the state of Georgia. She is focused on health and social law, consumer issues, and has given special attention to the young and elderly issues in the state of Georgia during her 22 years of service on local and state government levels. Senator Unterman has been twice named the Public Health Hero by the Georgia Public Health Association. She served as chairman of the National Association of the State Legislature's Committee on Human Welfare and the honorary chairman on the Hunger Initiative, and has been a member of the American Legislative Exchange Committee for many years. Serving on the Health Committee, Senator Unterman received her undergraduate degree as a social worker from the University of Georgia and her nursing degree from Georgia State University. And last but not least is Russ Childers. And Russ Childers joins us today. He is the state president of the Georgia Association of Health Underwriters. Russ has over 38 years of experience in the insurance industry and has served as an independent broker of life and health insurance investment products for the past 25 years. He has served as the state president of the Georgia Association of Health Underwriters and as the state legislative chair for a number of years. He was awarded the Health Underwriter of the Year in Georgia in 2000, and he has served as the chair of the National Association of Health Underwriters Legislative Council and is currently serving as their president. He completed their studies at Georgia Tech and Georgia State University and has a political science degree from GSU. And with that, I'm going to turn it over to our panel to first open up with just opening comments. And once we hear the opening comments from each one of our panelists, then I'm going to start to facilitate our conversation. And really, it's going to be a conversation because public policy is going to focus not only on innovation and the workforce development in the state, but I know we're all very interested in the health information exchange. And as Russ and I have talked, there is also the health insurance exchange. So HIE means two different things in many arenas. So we're going to focus on that this afternoon. And so with that, I'm going to open it up to Dr. Hutchins.
Good afternoon. Just wanted to say that also that wasn't mentioned in my bio that I'm here on behalf of the Georgia Health Information Exchange Board, and also I work with the Central Georgia Health Network, and I'm part of that health information exchange in Macon and the Central Georgia region. And one of the things that we also want to make known is that public policy is one area where physicians, let's say over the last decade, have really not participated that well. And I'm glad our distinguished senator of the Health Committee is here today, because what I hear all the time is that the legislature, especially the Georgia General Assembly, does not hear from physicians. And there's not enough input in public policy, and what virtually happens is that policy is implemented without our input, and then it's corrected after we scream about some of the changes that are occurring, including some of the recent changes that have occurred in the final ruling regarding ACOs that basically are more beneficial and actually were a result of physician involvement. So that's where I'm coming from today, is mainly looking at things from the physician perspective and how we can influence public policy and how public policy can be made to work for everyone.
Thank you, Dr. Hutchins. And Kelly?
Hi. I'm also on the GHIE, or Georgia Health Information Exchange, Inc. board, as well as Dr. Hutchins. And the commissioner of DCH, David Cook, is also a board member. We also have the deputy commissioner, Blake Fullenwider, who was just appointed, also is on the board, with amongst probably 25 or so other healthcare stakeholders around the state. So when I took this position as an interim state HIT coordinator, just maybe about 15 weeks ago, we realized really that Georgia is at a place that we need to move fast and quick. And DCH, having the grant, been awarded the $13 million grant from the Office of the National Coordinator, looked around and said, we can't drive this alone, and nor should we. We need to understand the pain and joy of the provider community, the hospitals, the patients, and other healthcare stakeholders. So we really turned to two places, the GHIE and their board, and the committees that are quickly forming, as well as the Georgia Health Information Technology Regional Extension Center out of the school, the Morehouse School of Medicine. And together we formed what we often refer to as a golden triangle of driving HIE in this state. And today I hope we can talk a little bit more back and forth about what that means and the roadmap for that and where we're headed. Thanks.
Thank you. Senator?
Thank you. Thank you for having me here. And can you hear me? Yes. I'm used to having a microphone right up here next to me. I appreciate y'all's opportunity to have me here. And I encourage you that if you're not involved in public policy, to get involved and to know your senator and to know your representative, because we really do have an impact on your pocketbook and on your business. And developing legislation, just like the physician was explaining, oftentimes if we do not receive input from our constituents, we do sit down under the gold dome and take a pen and piece of paper and say, well, we're going to do this. And unfortunately, we do have unintended consequences. So that's why it's so important for you to be involved. One of the things that I wanted to explain to you is to tell you, most of my time I am the chairman of the Health Committee, but I have served on appropriations for many, many years now in the General Assembly. And I spend about 12 months of the year working on the Georgia state budget. And it's an ominous task. It took me about 5 years to understand the budget. Yes, you can read the budget, but you don't know the ins and outs and the manipulation of the budget. We call it creative financing. and understanding whose pet projects are put in or taken out. So I serve as the subcommittee chairman for Department of Human Services, Department of Community Health and Behavioral Health, disabilities and addiction diseases. So it's a huge task. My budget is equal to the education budget in the state, and then there's about 10% that's left over that the rest of the folks like DNR and corrections and people like that fight about. But one of the things I wanted to tell you, the impact of health care in Georgia, that there are more than 1.7 million Georgians that are actually on the public rolls of Medicaid and Peach Care for Kids. And also another significant part of Georgians' health care is that Georgia takes care of 700,000 folks through the state health benefit program. That's a lot of teachers, a lot of state workers, bus drivers, you name it that's on the rolls. So that's a huge task, and that's part of the budget that I'm over. One of the things that the Affordable Health Care Act has put into place is the recommendation and actually the law that approximately 650,000 new people will be added onto the rolls in the Medicaid system. And the reason I'm here, I think, is to tell you that we cannot afford those people. We have already cut our budget in the state of Georgia 21% in the last 4 years. Our budget now is down to $16.4 billion. We already have what we call a Medicaid gap in our budget, that we cannot afford those people, and we're having to supplement that money from other parts of the budget. So if you include the new approximately $650,000 people, the state of Georgia would be broke. We cannot afford to add those people onto the Medicaid rolls. There is absolutely no way. And we would be right up there with the state of California. So along with that, our other problem coming up this year and in our previous years has been in our unemployment. Georgia has one of the longest sustained, highest unemployment rates in the nation, and we've hovered around 10 to 10.3%. And unfortunately, we're having to pay back that money. We owe $750 million back to the federal government. On September 20th, we made an interest payment that was about $21 million on that money. So that was just the interest. So I think the reason I'm telling you this is to tell you that we are living in very dire circumstances. Georgia is one of 7 states in the nation that still maintains a AAA bond rating, which is very important to you, because as we're looking at capital investments, whether in the university system or whatever kind of system, improving IT, these capital investments have a huge, significant impact when you're looking at that AAA bond rating. So it's very important to maintain that, and that's part of our fiduciary responsibility in state government, is to make sure that we stay solvent, that we manage, and we do well in these times. I did have one other thing, and I'll just take just another minute. I just got a message from the governor's office at 11:45, and our net tax collections for the month of October have improved significantly, 5.4%. when you compare October of this year to October of last year. So we're making gains. The first 4-month quarter from this year to last year was 6.8%. So we're really improving. It's just very hard times, and it's very hard times to be an elected official. Yes, we want to be creative. Yes, we want to improve our services, but it's very difficult times.
Thank you. And Mr. Childers.
Thanks. I'm a health insurance agent. I sell health insurance to individuals and small businesses. So I sort of look at myself, along with doctors, as the human interface for the system. A lot of times you think that folks go online and learn about things and that kind of thing, and that's one of the things I want to talk about in this brief time that I have. I think that while we talk about health IT all the time in terms of medical records and people being able to communicate with each other within the system, one of the things we don't look at is the opportunity that we have to help individuals in the system. Healthcare today, outside of losing your job, is the biggest financial event or the biggest financial risk that any individual or family has in the state of Georgia. In a matter of hours or at most a couple of days, most people can spend more money because of a health event than they would ever imagine spending on anything else. And that risk is something that they worry about. I think that as things develop in health IT, that there's going to be a lot of opportunity for new delivery systems and new insurance products to fund those delivery systems along with the state. But there's a very big key to those systems working to me, and that's people being comfortable with the use of those new systems. Because of the risk that it entails, people, if they're not comfortable using a new system, using a new insurance product, are not going to use it. And I think health IT can provide that degree of comfort for most of the people out there. Most of the people out there, luckily, aren't as old as I am, and they're actually used to working computers from the time they're 2 or 3 years old. So they're very comfortable with Facebook and all the different social media and using their computers to gain information. And I think that's something that we need to pay attention to as we move forward in all of these systems, is the opportunity of health IT to provide information to individuals to help them both access the right kinds of care, and number two, to take the risk out of accessing that care to their family's finances. So I look forward to talking this afternoon about all the issues.
Thank you. And when the Stimulus Act came out in February of 2009, the healthcare IT industry, we kind of were rocked by it. We've grown exponentially since then. There were hundreds of millions and billions of dollars dedicated towards healthcare IT with a fundamental foundational goal that at the federal governmental level, we will have a national health information network. Now think about where we were in 2008 with doctors. Some had electronic medical records, some of them were on paper. Everybody felt like they were on disparate systems. And so the government recognized several things. One, we have 5 main policy priorities to focus on coordinating care, engaging patients and families, reducing the cost of the healthcare system, and protecting patients' privacy and security. And through those foundational goals, to set a framework where providers would exchange information so that we could improve the outcomes of care through clinical care coordination. But in order to do that, our docs that were on paper, our doctors that were on disparate systems, all had to be on systems that were interoperable. And we're still working towards that. It's only 2011, and so this came out in 2009. But one of the ways to motivate us to move, to stop doing what we were doing and change behavior, was to throw $20 billion at the providers to say, we will financially give you incentives as Medicare and Medicaid providers if you will adopt and implement an electronic health record system. Because a lot of us could go out and buy one and put it on our shelf and it looks real pretty and we get a check. But if we didn't implement it and change our behavior and report on certain measures and goals to actually cause us to change our behavior, the end goal of clinical care coordination to reduce the cost, and the cost that the senator was speaking of, would be lost. And so with those financial incentives, as Justin and the panel earlier talked, they spoke about how about $1 billion of that has been paid out to providers at this point in time. And we talked about how many hundreds of thousands of providers that we have. And so Dr. Hutchings, one question that I have for you as a provider is, do you think the Medicare incentives, which on Medicare for an individual physician, the maximum amount they can receive is $44,000, and then on Medicaid it's a little over $63,000, and you have to pick one program. You can change your mind once, but otherwise you're limited to those amounts. Were those financial incentives sufficient to motivate providers to actually adopt records, in your opinion?
Yes and no. Yes, in the sense that pretty much all the providers see it and say, okay, if I don't get on board, then I may not have an opportunity to get that money. Because a lot of us see this as just another program like Cash for Clunkers, that if you don't adopt early and get in early, the money will not be there. Who who around at either the state or federal level can say or guarantee that in 2015, 2016, that I'll still get $63,750 from Medicaid and $44,000 from Medicare? One of the other issues that kind of is disturbing to physicians is initially, yes, you can qualify for one program or another, or let's say the e-prescribing and Medicare programs. You can qualify for one or the other, but let's say you don't adopt, you can get penalized for both. And you're still paying out of your pocket. So it is, in a sense, it does help that everyone is doing it, but there needs to be a simplified system where we can, as physicians, can adopt the new technology, that we don't end up paying for everything that we adopt. As we've had discussions here today, physicians in our industry, we're one of the few industries where we pay people for the things that we give away. I mean, we're paying for all this information that we're gathering, and we're giving it away for free. We're not getting reimbursed for this. Who's reimbursing for this? And I understand at the state and federal level that there are only so many dollars to go around. But it has to be a fair system where at least we get paid for the work we do. We don't mind working, we don't mind treating patients, but there's going to be a negative impact down the road where physicians are basically going to vote with their feet and say, okay, you want me to see all these baby boomers, and believe it or not, I'm one of them, but you're not going to pay me to see these baby boomers, and you expect me to stay in business. And even if our partner, let's say, join a hospital system or something, there's still someone is going to have to pay to play.
And that goes, everything gets motivated by money at the end of the day. And that goes to one of the main policy-driven initiatives, which is to reduce the overall cost of our Medicare program. And in order to reduce that cost, the other concept was to engage patients and families in the exchange of information, to go to the patients who are insured and to say, will you use your iPhone to look at your lab results? Will you use your iPhone to set consults with your doctor? And from an industry standpoint, Russ, I was going to ask you, are you seeing patients who are willing to engage using electronic health record systems or some type of electronic exchange to try and reduce cost? Do you see patients in the insurance industry?
Well, certainly you particularly in the younger population, you have a lot of ability to do those things and inclination to do those things. When the doctor was just speaking, I happen to think that my former doctor figured out a way to avoid all of that. He retired. He decided he still doesn't have a computer in his home. He decided he didn't want to mess with a computer, so he retired. So there are ways that people can adapt to things, although they're not normal adaptations. Yes, I think it works. I think one of the things that limits that somewhat is the ability of physicians to work 24 hours a day. I know I have my doctor's cell phone number. I don't think there are many people in Atlanta that probably have that. I live in a small town in South Georgia, Americas, and we have about 35 physicians in town. I know my physician really well. We go to the football game on Friday together. He gave me his cell phone number knowing that I'm not going to call him after 9 o'clock at night, that I'll go to the emergency room. But if I have a problem at 4 o'clock in the afternoon, or I have a question about a medication that I'm supposed to be taking, or something like that, I can access the information pretty quickly. He also knows that I'm insured, which helps out because he's going to be reimbursed for some of that. Although there are some questions these days to the extent to which insurance companies will reimburse for electronic access. I think that's something that's changing pretty quickly in the insurance industry, is they see that perhaps an electronic access is less expensive than a person-to-person access, and therefore they're more willing to pay for a less expensive procedure. But you do see some adaptation, but you're not seeing it widely. You're not seeing it generally. And part of that has to do with the fact that to a great extent, the general population isn't very perceptive of the invasion that on other people's privacy that can entail. Yeah, I think the more people use it wisely, the more it'll be available.
And that,
Just add one thing to
absolutely,
that.
go right ahead.
I talk to providers and I visit hospitals and providers all over the state of Georgia. And the one thing I'm hearing is that this could not have come at a worse time because we're in the middle of a recession and they don't have the capital outlay. They want to do it, but they can't afford to do it. And the reimbursements from their patients that are paying them, whether they're a private pay or insurance payment, they're not getting those payments. They're concerned about getting the payments on time and keeping their business running. So they're good business people and they want to expand. It's just that they can't afford to. The other thing they're concerned about is the federal government. They're cutting back on Medicare payments. We're waiting on Congress to see if they're going to cut payments. We don't know what's going to happen with Medicaid and Medicaid reimbursement rates. And the providers are just in a pickle, just like the rest of the economy's in. The other thing I hear from patients, and when I'm at the Capitol from my constituents, and in the Senate Health Committee, I hear the issue of trust. A lot of people that are not used to computers and they just don't know what to expect, and they're afraid of hacking, and they're also afraid of big insurance companies. They're afraid of them knowing their whole history because they're going to be denied if they have to have a prior condition. I know that law changed, but people are still afraid of it.
Sure, sure. And from a state standpoint, oh, Kelly, go right ahead.
I just want to comment on sort of what I'm hearing here. So starting with Dr. Hutchins and your question to him about is the incentive actually working? So I see things on the other side. So in my shop, we have the Medicaid incentives program that I have a team led by Jackie Coffey, which some of you may know, reaching out to providers and facilitating that program. We launched on Labor Day, September 5th. And what we see is, and I think we've given out now almost $13 million in 2 cycles that we've had for September and October, is that it's the early adopters. So those that adopted, both hospitals and professionals back in the mid-2000s that have been doing this already have come and said, we're ready, we have our patient volume calculator, and they go through the process. So we haven't seen where the incentives are getting somebody who's new to this process yet. And there have been teams that have worked with Georgia HITECH that are in our pipeline, we just haven't seen them yet. So I think it is an incentive for some, but others that have already been doing this for a while. What I think is a better incentive, and that's where the health information exchange comes in, and then going back to both what you said about trust, as well as providers, the outlay of funds of how to do this, is through the health information exchange. I know you probably are going to ask me about that, but we have 3 phases coming up, and the second and third phase, and all within 2012. The second phase offering core services, what you would expect to see in a push and pull environment of a HIE, more robust HIE. But it's really going to be that third phase delivered before the end of 2012 that can both incentivize providers to, that I think, in addition to the money, of course, will say, oh, if I have that certified electronic technology, not only can I get the incentive, but then I can access these other services from the statewide HIE that will help benefit my workflow, or what have you, and that will help them to make their office more efficient and more cost effective. And the whole HIE is predicated on trust. So at DCH in my office, along with GHIE and the Georgia HITECH together, that's a really important thing, is the trust factor, how we build things that are transparent, open, collaborative, who we involve from a strategic standpoint. So if anyone were to look back at our policies that we're developing or having to develop, who was involved in that, how were those decisions made? We keep that right here as we pull that together. And then as part of the process, we're actually working with some firms that will help us understand the provider community, the healthcare stakeholders, and the patients. What are their specific needs and wants? So that we don't architect this in a way that is our assumptions, that we actually know. We want, and there's a CIO who's always talking about, I want you to manage my provider directory. I will pay for that. So that then translates into our financial sustainability. So we want to hear from providers. We're putting those mechanisms in place with members of my team and DCH, as well as Georgia HITECH and GHIE. So I just wanted to mention that because I'm hearing that it's not just money, and you can't just go out and buy this system so that you can get $60,000. That's not what it's about. It's being able to transform and then use that, make that process more efficient so you can deliver better health care and get all those great outcomes that you're looking for.
So just to pull some points out that all of you have hit on, we started out with, do the meaningful use dollars motivate physicians to adopt and implement? And now we've gone to, well, it may not be that, and we've kind of flipped over to what does incentivize physicians to get on board with having an electronic medical record system. And Kelly, your thinking is that the health information exchange, as it's developed, will provide additional infrastructure to the physicians to make their jobs easier, their workflow easier. There is one thing that I'd ask you to do is to recap the phases and the timing just in a short synopsis, because there are so many providers and health IT companies that are in the audience today. And the Health Information Exchange in the state of Georgia, we got a grant for $13 million to implement this grant and to implement the Health Information Exchange in the state. And everyone is kind of sitting at the edge of their chair saying, okay, what does it look like? What's the timing? So if you can recap just the timing and what those phases, when they'll hit, so everybody can get that down for their own strategic planning.
Sure, and I'd say we've just confirmed this. So our first phase, we're targeting the beginning of Q2 in the April timeframe. And this is, we're at a bit of a swag of this right now, but it's pretty solid, I would say. And that would be, we're focused on direct project protocols, so secure messaging, the exchange of secure messaging. And then phase 2 in that September or late Q3 timeframe, that would be the more robust core services like a record locator service or a master patient index included in there. And then phase 3 being those value-added services around immunizations and claims and eligibility. And again, I use those as examples for phase 3, but it really depends on the user research, provider research, and that open collaborative approach that we take so that we're building the right services that providers want. Because the HIE is essentially standing up a business. You can't build what you think somebody wants. You have to do that product development and user research.
And Senator Unterman, can you speak to, from the policy standpoint, is the state doing anything that either supports or goes in line and kind of parallel with what the HIE is doing? Are there any committees working on anything?
Well, we have, and Mr. Childers is working on the Health Exchange Council. That legislation was killed last year. The governor did have a proposal for it. It died both in the House and in the Senate. I think if legislation is put in this year, it will just be I guess you call it shadow dressing. It'll just be a bill to say to the feds, yes, we have a bill on health exchanges, but it will basically be symbolic. And I think that it will have a very difficult time in passing the General Assembly. Our stance is we're in a lawsuit with 24 other states that are fighting the Affordable Health Care Act, and we're going to continue to pursue that, and we've done well. Our Attorney General has done well with the other in court. And my question to the General Assembly is, well, if we're not going to do this, then what are we going to do? We know that we have so many uninsured Georgians. How are we going to take care of them? And from a political standpoint, that's an ominous statement. And how do you pass it on down to the bureaucracy? How do you formulate that policy? And I think it's part of the problem with the economy now. We're kind of in a state of flux. We're holding on to what we have, and we're waiting on the next presidential election to see if the Affordable Health Care Act is repealed. So the big question is, if it is repealed, what are you going to do? Because, like I say, the politicians still have the people knocking on the door. We don't have insurance. What are you going to do with us? And we're still having to make our dish payments and all the other payments to be able to help these people.
Right. And Russ, can you give us an insight into the difference between the health insurance exchange that you're working at with the insurance industry versus the health information exchange that Kelly is working on with her phases?
Sure. Sure, I'll try. The health insurance exchange is, I guess you could better describe it as an insurance marketplace for individuals and small businesses. It'll be a place on the internet that citizens of Georgia can go, whether they're individuals or the owners of small businesses, to find out what kinds of insurance are available in their parts of the state, what the costs of that insurance is, who they can contact to purchase that insurance, those kinds of things. Unfortunately, there is also in my business something that people talk about as a health information exchange, that is a place where you can go and get information about health insurance, but you can't buy insurance there, it's just information, which makes it even more confusing when you get to the actual health information exchange, which is more of an exchange of information about people's health and medical records and things like that. So it's, the terminology has gotten very confusing. In fact, for the first 2 or 3 days I was working on my remarks for this, I was working under the impression that the HIE was the Health Insurance Exchange, not the Health Information Exchange. But it is confusing, and if it's confusing to us, you know it has to be confusing to the general public. And that's one of the problems in all this. We need to keep in mind that we're trying to communicate things to the public so that they'll know how to obtain coverages, how to have access to their records and that kind of thing. And while I'm talking, if I could, just for a second, I'd like to mention a problem that I've noticed lately. And it's something that the real HIE, the Health Information Exchange, I think is going to help with. I had a young man come to me about a year ago wanting to buy some life insurance. It turns out the young man, from the time he was 7 until he was 12, had a very serious disease. He's 37 now. When we started trying to get copies of his medical records, they don't exist anymore. The attorneys for his doctors basically told them that they were better off getting rid of the records after the 7 years that the government required them to have them, because it just offered an opportunity for an attorney at some future date to ask for those records and sort of dig through them to look for something that was done wrong. I had another client that had heart surgery 12 years ago to replace a valve and then have a stent put in. He's older than this gentleman, but he's got the same problem, in that those medical records don't exist anymore. So I've advised all of my clients to contact their physician and get a copy of all their medical records that they can find, and even go back to older doctors and get copies of the records. Now, the problem with that is, if you think about it, that leads more credence to what the doctors are being told, that people are searching through their medical records looking for problems to file suit over, because there are more people asking for their records. So it's sort of a circular function, but the electronic record will eventually take the place of these paper records, be easier to store, and maybe people will maintain them for longer periods of time, and maybe it'll be easier for an individual to have his own record. Several times I've talked to my doctor about having copies of my record, and they've gotten sort of nervous about things. And I think that's part of the legal system we're part of. Really what I was interested in is just putting it in a file so I'd have it in the future. But that's a problem that isn't known very well, but people should take it into account in all of this.
Leave it to the attorneys. One other item that I do want to touch on is really the workforce. You know, as we look in the state of Georgia and we focus on jobs, as Pat mentioned earlier today, there are jobs in the state of Georgia that focus on healthcare IT that are open and available, but the workforce that we understand that it's available to fill those jobs doesn't have that same level of skill. Maybe it's a high technical skill. And so I'd like to hear, Dr. Hutchings, from the provider standpoint, do you see providers trying to hire IT professionals or people who have experience in programming? Do you see a need in the provider practice for that workforce?
Yes, yes, there's a need, but as you just said, good workers are hard to find. And when you move out of areas like Atlanta and some of the metropolitan areas, it becomes even more difficult. I mean, you have problems with access as far as high-speed internet access. And as far as I know, basically you have two populations of physicians now. Believe it or not, most physicians are now employed. Doesn't matter race, creed, whatever. Most physicians are now employed, and the vast majority of physicians who are coming out now that we really haven't talked about are employed. And believe it or not, they're the most technologically savvy. You know, us who were in private practice years ago and, you know, switched over to being employed. But the majority of physicians coming out, you know, are in a different environment. So you have a group that basically, yes, needs those services. And there are groups out there that are providing that service because realistically, as our senator just said, you know, a lot of these doctors are hurting. Since about 2008, when the economy went bad, I mean, there's a study, I have a twin brother who's a physician also, and we looked at something yesterday, and there was an article in one of our medical journals that said that patients are basically delaying care and delaying visits to their physicians. And we looked at each other and said, well, who funded this? All they had to do was ask us. We already know that. You know, it's obvious that when things go bad, people hold on to their money and stuff. So a lot of physicians, they cannot afford their own IT department. I work for a family medicine department. We have 15 physicians, about 30 residents and fellows. So, and we work through a hospital system. So yes, we do have our own IT department. But most physicians are having to contract it out because they don't have the wherewithal or the employees who have IT knowledge or backgrounds that can do what needs to be done in the office. And one of the things that, again, at the Georgia HIE board that we've talked about is you can get a system, but then, as you mentioned, if you don't use it, what good is it? And even if you have a system and use it, if you're not able to sustain that and do upgrades and do the other things you need to do down the line to, you know, stay competitive, how are you going to help your practice? How are you going to help your patients?
And Senator, are there any committees that are working on workforce development, especially in the HIT sector for our state, so we can fill those jobs and then grow the jobs once you fill those jobs?
Yes, as a matter of fact, they had a hearing last week at the state capitol, and I was talking to Senator Loudermilk, who was on the Economic Development Committee, and he said that it was testified in that committee that there were 5,000 to 10,000 positions open in health IT that are available in the state of Georgia. I've also talked to some of the technical schools, and they say that it's not that high. 10,000 is a high number, but they believe 5,000. So economic development is looking at it as a separate segment that needs to be filled. And I can tell you in my district, I'm from Gwinnett County. Sharon Bartles is the technical school director, and I know they are specifically focusing on the workforce development. We just built a new life science center there. Of course, we're the home to Cisco and McKesson and data centers in Gwinnett County. But there's a huge demand, and we see that as a way to grow our economy. That's what every state is looking at. So yes, we are specifically targeting that, and I think you'll see more and more money put into that so that we can fulfill what he's talking about.
Okay. And I do want to offer an opportunity for the group out here to ask questions as well. So if anybody has a question, if you'll raise your hand and a microphone will be brought to you. And while we're doing that, I'm going to ask one more question for all of our panelists to comment on. And you can feel free to pass if you'd like. But with the Medicare fee schedule for the physicians on Medicare, they have now announced, as we talked about earlier today, they're not going to go with the 29% decrease in January. We're going to go with 27.5. So the concern there being from a public policy standpoint, we put all these systems together. We have these patients who need us. We have the patients who don't have insurance. We have the 650,000 people who will be added to Medicaid rolls in Georgia in 2014. And so what does this do to our provider population with regard to this decrease? And are there any other things that we can try to do from a state standpoint to alleviate the potential of the providers pulling out? So that's a pretty long question, but I'm going to let each of you comment it briefly while we have the microphones go around. So Dr. Hutchings, since it impacts your financial dollar the most, you can start.
Yeah, I'll try to be brief, but from the state standpoint, it will be difficult because Medicare is a federally administered program. the big problem is the government's known for well over a decade this day was coming. This could have been repaired over a decade ago, and it would have cost 10 times as less to fix. But according to what was going on in the economy, it just wasn't done. All these patches have occurred mainly because physicians don't have a true lobby that can go to Washington and go to other places and say, hey, we're sick of this. The sustainable growth formula has to be repealed, and there has to be a real formula to deal with how physicians get paid. What's going to happen if, let's say, this 27.4% cut goes into effect in January, is that physicians basically won't see Medicare patients. You'll have a few that will see anybody and everybody. You'll have another few who are going to totally withdraw from Medicare. The rest will probably delay scheduling Medicare patients. And what will probably happen is, instead of you getting an appointment with me in a month or let's say a week, it may be 2013 before I schedule you. Because now I've got all this electronic data, I got these electronic systems, I can tell how much I'm getting paid from Medicare and all this, and I can see what percentage. So what's going to happen is either there's going to be a delay in you being scheduled, or the percentage of Medicare people who are being seen by those physicians will be dropped. So instead of, let's say, you see 25% in your practice, you may drop it down 5%. So, that's basically what's going to happen, because physicians are tired of, and that's the other, just real quickly, is that usually when these patches occur, then there's a delay in payment, or the physician has to go back and refile those claims, which is another administrative burden.
Kelly, before you start, if anybody has any questions, raise your hand high and Powell will find you. Go ahead, Kelly. Do you have any comments on any incentives or any other ideas?
Yeah, I'm going to have to pass on that specific question, as that's more Jerry Dubberly, Medicaid Director question, so save time.
I feel like the physician said it succinctly, but I would like to add one of our problems in the state of Georgia is physicians who are they're either retiring, just like he was saying. So we have the baby boomer physicians retiring, but we also have young people who will not go into medical schools anymore. And the reason being is that they cannot pay for what the medical school cost. So the state is focusing on workforce development for physicians. We're also focusing on the rural areas, trying to entice physicians to do their internships and residencies in the rural areas and stay in the rural areas. We have a great program at Mercer, but it needs to be expanded because we do have two Georgias. And one is the metro area and one is the rural area. And unfortunately, the rural area is suffering greater consequences because of that.
Mr. Childers.
Well, a couple of things. Doctors may delay the visits, but that doesn't mean people are going to do without health care. They'll go to the ER, which is already overcrowded. I certainly understand where you're coming from here, and I can't really see any world in which a 27% cut in income is a good thing. But I think what we're getting to here is the answer to the question of why Congress was talking about health care 2.5, 3 years ago, and that is cost is the problem. Medicine is extremely expensive, and to some extent it's more expensive than our country can afford right now, and it's getting more expensive every day. And we've got to figure out a way to deliver medicine in a good way that's affordable. I told the Insurance Exchange Committee I serve on that the governor appointed, everybody danced around this issue, and finally I just brought up the fact. I said, everybody here knows that when I go to see an individual and show them how much an insurance policy is going to cost, or I go to a small business and show them what their plan's going to cost, they don't complain about what doctors are covered or what procedures are covered. The only thing they bring up is how much it costs. But they know they have to have it. So I think that's where our nation's conversation needs to be, rather than on all these peripheral issues about Sure, there's problems with access, but where does access go back to? It goes back to paying for that access. There's a lot of different issues, but they all go back to cost. The other thing I want to mention, and I didn't think about this, I was too focused, I guess, on my particular questions in my head. I'm from a community that's got a rather unusual opportunity right now. I'm from Americus, Georgia, and we had a tornado 4 years ago that went right over the top of my office where it was across the street from the hospital and tore up our hospital. And in a month, we're going to open a new, brand new, on a new location, 76-bed hospital that's going to be pretty much state-of-the-art. Unfortunately, I had to be in the hospital for 3 days back in June, and our temporary hospital didn't give me any medicine without a scan of my wristband and a scan of the medicine. They didn't do a test without a scan of my wristband and a scan of the prescription. They didn't do anything. Well, the way I explained it to my nurse was, I didn't see any opportunity for you to make a mistake, with the exception perhaps of washing her hands, which she did. I sort of kept an eye on that. I've had some experience with folks in the hospital. But you know, that's an unusual situation. Up here in Atlanta, you have a new hospital built every once in a while, but in the rural areas, we add on to things and we change a little bit of what we're doing, but we never get an opportunity for a new system. And it's really interesting, the differences between what we had and what we're going to have, because to a great extent of health IT and the impact it's going to have on the delivery of medicine in town. The other thing I've noticed, Doctor, is because we've been sort of out of the medical business for 3 years and now we're getting back in it, we're bringing in a lot of young doctors just out of medical school. And without exception, they're going to work for the hospital. And their answer when you talk to them is, I can just practice medicine, which is what I went to school to do. I don't have to run a business. And you can understand that. They want to practice medicine. They don't want to run a business. They don't want to manage a business. They don't want to worry about hiring people and discrimination laws in hiring and all the other things that businesses deal with. So I think it's going to be an interesting place to observe over the next year or two as it opens up and gets up and running. And I would suggest, I'm sure our folks down there would love to have people come and visit them and see the kinds of systems they've put in and see how they're operating. Some of you probably provided those systems, so we appreciate it.
Thank you. And we have one, question right here. Go ahead.
You talked about the government reducing their payments on the Medicare, but also insurance companies are reducing their payments also. So it's not just the pressure from government reimbursement, it's also private reimbursement. And I wonder if anybody could address some of the incentives that maybe we could put into the system to improve quality and improve efficiency, moving from a fee-for-service to the accountable care organizations, patient-centered medical homes, uplifts of payment for quality, bundled payments for particular episodes of care. Do you see any of these kind of innovations actually making an impact, and can the provider community migrate and accept those incentives outside as an alternative to fee-for-service?
And we're running short on time, so I'm going to ask whoever would like to answer that to go ahead and answer it. And then any other questions, we'll have the panel up here afterwards that you can come up and ask. So go ahead.
Yeah, I see a lot of opportunity in those areas. It's the question is, how much integration are people going to be willing to accept? Because one of the questions we talked about earlier during our discussions before the panel was insurance companies buying providers, buying hospitals, buying doctors' practices, hospitals opening insurance companies, all of those kinds of interaction. And to what extent does the payer, being the provider, provide an opportunity for problems to develop, let's say, in terms of the level of care that's delivered and those kinds of things. I think one of the things probably is important or more important than the financial considerations there is we have to change people's attitudes so that people understand that more care doesn't necessarily mean better care. So for example, if you can treat a heart condition with prescription drugs rather than a stent, it's less expensive. But if you talk to the patient, most of the time the patient thinks the stent's better, even though it's a lot more expensive. So those are the kinds of issues I think we're going to have to, along with the privacy issue and whether finances become a factor in what kind of care is delivered. I think those are the kinds of issues we're going to have to discuss in terms of adopting those kinds of things. I think insurance companies are very open to all of these new methods and looking into those methods because they're at their wits' end in trying to determine and trying to develop ways to both deliver care and control costs. So.
Did you want to comment on that? Well, with that, what I'm going to ask, I know we have a couple other individuals who might have a question, and so our panel will be up here to answer those questions. And we want to thank Greenway for sponsoring this module, and we want to reemphasize the fact that these policy position papers are there for comments to receive, delete what you think is not appropriate. But it seems that the overall goal of the healthcare delivery system is to integrate the entire healthcare delivery system together using some type of information technology, which is why we included both the state policy, our state senator, the insurance industry, and a provider, because it's a healthcare integrated network, and that's where we're going to be looking at the future, is all of these pieces coming together to provide healthcare. So I want to thank the panelists for participating today. Thank you.